Class, now we're going to talk about our next exemplar, which are the National Patient Safety Goals. And I want to talk about these individually to let you know the importance of why these particular goals were instituted. The National Patient Safety Goals were established back in 2002 to help accredited organizations address specific areas of concern in regards to patient safety. They looked at all the data and saw where were the problems coming from, okay? And so the first set of the National Patient Safety Goals was effective January 1st back in 2003. And that seems really recent, but you have to realize this was 17 years ago. And the Patient Safety Advisory Group advises the Joint Commission on the development and the update of the National Patient Safety Goals. And the Patient Safety Advisory Group consists of a recognized patient safety experts who consist of nurses, physicians, pharmacists, risk managers, clinical engineers, and other professionals. Hands-on experience in addressing patient safety issues in a wide variety of healthcare settings. It advises the Joint Commission how to address emerging patient safety issues. Okay, and so no new goals were set for 2016, but now phase 2 is now in effect, and hospitals are expected to establish and implement policies and procedures for managing clinical alarms and to educate individuals about alarm systems. So one of the concerns was about alarms. We put these on patients to keep them safe, but when the alarms go off, it seemed like patients were still falling. Controllers with medication were still having safety issues with patients in regards to medication infusions. Maybe they would put a pad under somebody that would signify that the patient is getting out of the bed or getting out of their chair, and yet nobody was going to that patient's bedside when the alarms would go off, and they felt that it really needed to be addressed, okay? The next one, goal 1, was to improve the accuracy of patient identification. And this is where we got the policies and procedures of using at least 2 patient identifiers when providing care and treatment and services. So this is where that came from, because obviously we were giving medications and doing things, procedures, labs, surgeries to the wrong patient. So they developed this way in which we would properly identify the patient to make sure that we had the right patient, okay? This would also eliminate transfusion errors related to patient misidentification, which is a big safety issue if we're giving the wrong blood, if we're giving blood to the wrong patient. Serious consequences and even death can occur. All right. The next one, goal 2, was to improve communication, improve the effectiveness of communication among caregivers. And this was implemented through labs or x-rays that would actually see a critical result or a critical value and be sure that was immediately communicated to the nurse in charge of that patient. So it was necessary to report critical results of test and diagnostic procedures on a timely basis. Okay, so that is a very important way in which we've improved communication to provide that information to the nurse so she can notify the healthcare provider immediately. The next one was medication safety, goal 3, to improve the safety of using medications. And in order to do that, we are to label all medications, medication containers, and other solutions on and off the sterile field, perioperative and other procedural settings, okay? Reduce the likelihood of patient harm associated with the use of anticoagulant therapy. This is where they've implemented when patients are to receive maybe such as a medication like heparin it needs to be checked by 2 RNs. So there's those kind of safety precautions put in play. And in order to document that in the MARS, a lot of times you've got to have the signature of both nurses. Maintain and communicate accurate patient medication information. And then, of course, Goal 6 was to reduce the harm associated with clinical alarm systems, as I mentioned before. Improve the safety of clinical alarm systems. Goal 7 is to reduce the risk of healthcare-associated infections. And that is to comply with either the current Centers for Disease Control and Prevention, the CDC, hand hygiene guidelines, or the current World Health Organization hand hygiene guidelines. So these were put into play, okay? Because obviously hand washing is probably the #1 reason why a lot of organisms are transferred from patient to patient, in which they get what we call a nosocomial infection, where the infection occurs after the patient is admitted into the acute care setting. Implement evidence-based practices to prevent healthcare-associated infections due to multi-drug resistant organisms in acute care hospitals. Okay. Implement evidence-based practices to prevent central line-associated bloodstream infections. This is why hospitals have put into play policies in regards to things like central line care and why we do what we do to prevent bacteria or any type of organism getting into those central lines. Okay. Then again, implement evidence-based practices for preventing surgical site infections. And then again, one of the big ones was to implement evidence-based practices to prevent indwelling catheter-associated urinary tract infections. And this was a big one. This is why we don't put in Foley catheters unless they're absolutely necessary, and when they are put in, that we get them out as soon as possible to prevent these types of healthcare-associated infections that comes with indwelling catheters. Then number 9 is, goal number 9 is to reduce the risk of patient harm resulting from falls and to reduce the risk of falls. And then goal 14 was to prevent healthcare-associated pressure ulcers. Assess and periodically reassess each resident's risk for developing a pressure ulcer and take action to address any identified risk. And then to assess and periodically reassess those patients' risk for pressure ulcers. And then goal 15, the organization identifies safety risk inherent in its patient population. And identify patients at risk for suicide. And conduct a pre-procedure verification process in which universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. Obviously, that was happening in which this particular policy or goal was implemented. Mark the procedural site. And a timeout is performed before the procedure. And then for any more information, the National Patient Safety Goals for each program and more information are available on the Joint Commission website at www.jointcommission.org. And questions can be sent to the Standards Interpretation Group at that particular number or via the Standards online question form. So this is our National Patient Safety Goals. And you have a abbreviated version of these. This is the long version, but your abbreviated form does give you the same information, but kind of sums it up and a little bit easier to kind of go through exactly what those goals are of the National Patient Safety Goals. As you can see here, I brought up Appendix 3, which are the National Patient Safety Goals that I just went over with you using the PowerPoint. But as I said before, this is an abbreviated version, and you can see it starts from 1, 2, 3, 6, 7, 15, and then the last one here. So you have this in within your weekly lesson plan, okay, in regards to your lecture handouts, okay? So please know these, because these make great select all that apply questions, okay? There's a few more under medication safety. We know about alarms. These are the way in which we can prevent infection. Apparently these are some areas where they were seeing hospital-associated infections. Patients were also committing suicide, so they now ask that you identify those patients who are at risk for suicide, and then how to prevent some of the mistakes that were happening in surgery, okay? All right, lastly, what we're going to do is look at this case study, which kind of helps us understand a little bit more about the patient safety goals. All right, so we'll kind of read it together, and then I'll give you some of the answers. But before I do, I want you to kind of think about what you would do if you were in these situations, okay? So first part A is Carrie Brandt is admitted to the hospital complaining of severe back pain, vomiting and nausea following a urinalysis and MRI. Ms. Brandt is diagnosed with renal calculi, which is a fancy way of saying that she has kidney stones, and the physician orders administration of 2 milligrams of morphine sulfate IV, which you're just now enrolled in 123, and I know you know what morphine is, but it is a very potent opioid, and she's getting it through the IV route. So 2 nurses, Peter Martin and Danielle Sanchez, are present when the physician issues the verbal order. So Danielle, who is the client's nurse, withdraws a syringe containing morphine 4 milligrams per 2 milliliters from the automated medication dispensing system and walks to the client's room. When preparing to withdraw medication for a client assigned to his care, Peter glances at the dispensing receipt that was printed for the previous transaction. In particular, Peter notices that Danielle appears to have obtained twice the dosage of medication ordered for the client. Peter follows Danielle to ask about the discrepancy. By the time Peter arrives at the client's room, Danielle has administered the morphine to Miss Brandt. When Peter privately inquires as to the amount of medication given, Danielle replies, "I gave all of it, 2 milliliters. Peter points out that administration of the 2 milliliter dose means the client actually received morphine 4 milligrams as opposed to the ordered dose of 2 milligrams. Danielle replies that the additional 2 milligrams of morphine likely will not harm Miss Brandt and that she will monitor her closely. Danielle then asks Peter not to issue an incident report because she is afraid she will be reprimanded and possibly lose her job as a result of her error. So let's look at question 1. How do you believe the situation should be handled? Should Danielle report the error and explain your answer? Well, I know because you're all very honest and ethical. Of course Danielle should report the error. Because think about it, she gave the patient twice the amount of morphine that was ordered. And you will learn about morphine in your pharm classes, but morphine is a very potent opiate, as I said before, but it also has the ability to suppress respirations. We don't know how old Carrie Brandt is, the patient. We don't know her size. So this could be a very dangerous situation in which the patient could be given more than was ordered, obviously, but could cause some very serious side effects, causing the patient to develop a change in her blood pressure, because it does have a vasodilatory effect on the vessels. And so it may drop her blood pressure very low, or else it could also cause her to have a change in her respiratory status, causing her to suppress her respirations, where the patient is not able to breathe as deep, and the patient could very likely retain carbon dioxide and have some respiratory distress develop. So the client may be in danger of adverse events from the overdose, particularly respiratory depression, which could be life-threatening. Accurate data about medication errors is necessary for hospital safety measures. Plus, Danielle needs to own up to her mistakes. If this is ignored and if the error is not reported, Danielle may consider that she got away with something and could do something just as serious or more serious in the future. Okay? But this is a very, very serious med error. And if Peter walks away and does not report it, or does not make sure that Danielle does come forward and report her error, then he's just as guilty as the nurses who actually gave the incorrect dosage of medication. And I have to say that he is just as unethical as the nurse who administered it. So there's a lot going on here, and I know this can be a very difficult situation, especially when you're working with somebody, but the bottom line is we're there for the benefit of our patients and to promote safety as well as comfort, and it doesn't matter. It has to be reported. Excuse me. So that's exactly what should happen. And this could be something that you maybe have experienced now, or you've seen a nurse do something that is unethical or that is wrong. If you, even as a UAP or PCNA, see a nurse give the wrong medication or do something unethical to her patient, it is in your duty, your civic duty, to report that to the manager or else to the supervisor, because you know right from wrong as well. And just because you're not a nurse doesn't mean that you don't see when things are not done correctly, okay? So those are things that you may come across, and maybe this may happen to you as a nurse when you finish nursing school. How are you going to handle this very serious ethical dilemma? But I don't think it's that difficult to decide, because the bottom line is we have to be there and advocate for our patients and be sure that this error is reported. And if she needs to be reprimanded, she does need to be reprimanded. And if it cost her her job, it cost her her job. Okay? You can't let something like this go unnoticed and unreported. So, a very serious situation. So, question 2. What are the ethical considerations involved in reporting versus non-reporting this error? Think about it. Possible ethical problems that arise from not reporting the error include the endangerment of the patient. That's the first concern. The reinforcement of unsafe nurse behavior and a lack of error reporting transparency. There are no ethical problems in reporting the error because hospital staff will take the steps necessary to correct the error and provide education to the nurse. Maybe she will not be allowed to pass medications for a while, and maybe she has to go to a pharmacology course or a in-service on the seriousness of making medication errors. I mean, there's a lot that we could do with this nurse to let her be aware of the severity of the error that she made, okay? So that's one particular situation involving patient safety goals, which does apply to using medication safely, okay? So things like that, all right? So let's look at case study part 2. All right, let's move this up so we can see that. Okay, sorry about that. I went too far. did go too far. Sorry about that. Let's bring this down again. All right. Here we go. Michael Lair, age 28, has been admitted to the hospital due to a cold that developed into severe bronchitis. Juliet Wright, Mr. Lair's nurse, enters his room and introduces herself. She then washes her hands thoroughly and puts on a pair of gloves before obtaining Mr. Lair's vital signs and performing a client assessment. Throughout the process, Juliet explains each of her actions to Mr. Lair. Following the assessment, Mr. Lair inquires as to the plan of care, explaining that his physician has not yet informed him as to how his bronchitis will be treated. He also believes he overheard one of the nurses mentioning that he may need a procedure to remove fluid from his lungs, but it has not been discussed with him, and he is opposed to the procedure. The client is very worried and would like some answers. Juliet reassures Mr. Lair that she will seek answers on his behalf and thanks him for sharing his concerns with her. Next, Juliet pages the client's physician, who arrives on the unit from another area of the hospital. The physician explains to Juliet that he plans to administer a course of antibiotics to Mr. Lair and has no intention of performing any invasive procedures. In addition, the physician thanks her for sharing the client's concern and notes that he will speak with the client as well. Juliet and the physician discuss the antibiotics that will be prescribed, as well as the current plan of care for Mr. Lair. After speaking with the physician, Juliet returns to Mr. Lair's room and discusses the current treatment plan with him and the type of antibiotics that will be administered. She also explains what actions Mr. Lair can take to help improve his respiratory function and prevent complications, including frequent repositioning and coughing, deep breathing exercises. As Juliet finishes conversing with Mr. Lair, the physician arrives to speak with him. Wow, what a great nurse. I'm sure that's what you were all thinking as you were reading about her interaction with the patient. All right, let's look at question 1. What KSA competency does Juliet exemplify in her discussion with the patient, with the physician, and the client? That's a great question, because remember back in Nursing 100, we did learn about the KSA competencies. Remember the importance of patient-centered care. She sure exemplifies that with this patient. The nurse demonstrates knowledge of patient-centered care, exhibits comprehension of pain and suffering, as well as physiologic modes of pain and comfort, determines the extent to which client participation can affect safety, quality, and cost, determines methods of client and family empowerment, elaborates on the precepts of effective communication, involves clients and families as partners to benefit health, safety, and self-care, evaluates communication skills through client interaction, plays an active role in conflict resolution and compromise regarding client care, disseminates details of past and future steps of care at each stage of treatment, respects the client's experience and expertise, and acknowledges the client's desire regarding his involvement level in care. So that really explains how she really promotes and demonstrates patient-centered care, as well as advocacy too. The second question, identify the characteristics of Juliet's communication style that promotes safety. That's another great question. She is an excellent communicator, not only with the patient, but also with the physician. At every point in the situation, Juliet shares knowledge while dispelling rumors. In addition, she discusses in detail the current treatment plan, including antibiotics, frequent positioning and coughing, and deep breathing exercises. She really communicates that very clearly and very plainly to the patient. But at the same time, she gets the information that the patient needs to know by calling the doctor and making that a priority. Okay, so I really like the fact how she acted on that immediately and then got the answers for the patient and then communicated those answers to the patient. So he wouldn't be sitting there and stressing out increased anxiety, which obviously affect his healing and his present condition. So I really like that about her. She really did things right away and got the job done. Question 3, which of Juliet's behaviors and actions with the client and with the physician promotes safety? That's a great question, because we are really talking about patient safety, especially when we talk about those national patient safety goals, okay? Well, Juliet provides patient-centered care. We know that. But look what she did when she first came into the room. She washed her hands, she used gloves, and she really took the time to listen to the patient, listen to his concern. It wasn't all about what she had to do and what tasks she had to get done, but she really listened to the patient about his concerns. And she took that initiative to page the doctor immediately. She used that as a priority, and then she relayed the necessary information to the patient. And then I like the fact that the doctor said that he was coming in, and he did come in and discuss the situation with the patient. So all healthcare members involved really did do as they said they were going to do, and really helped alleviate the fears and concerns and anxiety of this patient, which was wonderful. It was a great team effort as I saw that. Okay, so that's really a great example of promoting safety in preventing the spread of organisms and possible infections, because think about it, this patient is already somewhat immunocompromised by already having bronchitis, and the fact that she came in and really used good hand hygiene was a great start to preventing any type of further infections with this patient. Okay, so let's look at the last case study, part C. Margie Blank, age 72, was admitted to the hospital for treatment of severe dehydration secondary to advanced and an untreated urinary tract infection. Mrs. Blank is normally very independent and does not often like to ask for help, particularly when she needs to use the bathroom. Richard Ferris, the client's nurse, recognizes her desire for independence, but also realizes that she is at a heightened risk for falling due to the infection and corresponding dehydration. Related signs and symptoms included weakness and dizziness. So Mr. Ferris talks to Mrs. Blank about the risk of falling, as well as the possible injuries that could occur if she were to fall. He does not want the client to lose her sense of independence, so he rearranges the chairs in the room so she has a clear line from the bed to the bathroom. And Mr. Ferris then discusses the need for Mrs. Blank to wear socks and or slippers when she walks to the bathroom to prevent further falling. Together, the nurse and client develop a plan of care that respects the client's needs and also works to ensure her overall safety. Very good. Another great demonstration. So let's look at these questions, okay? All right. Question 1. Describe 3 reasons why Mrs. Blank's situation represents an advanced risk for falling. Well, one risk factor is the fact that she's over 65. She's 72. And with dehydration, that affects vascular volume, which affects blood pressure. She may develop some orthostatic hypotension, which was stated that she does have some dizziness and weakness, and so this would definitely be another reason why she would possibly fall. And she has an infection, okay, which could have other manifestations such as the urgency to urinate, a high fever. All that could be other reasons why she is an advanced risk for falling, definitely. Question 2. Explain the nurse's approach to the situation described above. What communication and collaboration efforts does he employ? The nurse provides, again, that patient-centered care principle by implementing evidence-based communication techniques. He discusses the client's desire for independence, the risk for falling, and preventions against falling. He tried to respect her dignity and her independence, but maybe he explained it in a way that she realized that this was just temporary, and we sure wouldn't want her falling, breaking a hip, or causing a head trauma or something like that, which would further delay her healing and also cause her to remain in the hospital longer. That could really produce some very serious patient outcomes. So, but I like the way that he realized that she was in the past a very independent person and did not like to ask for help, but unfortunately because of her illness, it was okay to ask for help at this time, but he was going to assist her and not kind of take over totally. He let her be in charge somewhat and thought, what do you want me to do for you so that you can have your independence, but yet at the same time be safe so you're not at such a risk for falling. So I like the way he did that. He was very respectful of the patient. Okay. Question 3. Let's look at that one. Evaluate the nurse's recommendation for the client. Are these recommendations appropriate? Why or why not? The nurse is correct in removing obstacles from the patient's room because the patient may trip over objects in the walking path. And he did do that. He did move the chairs and everything, so she did have a clear path to the bathroom, which was a very good thing to do. And he also made her wear socks or slippers, which may not be the safest thing because sometimes those socks, unless they have skids on them, may be very slippery. So maybe it would have been more advisable to wear a shoe with a sole that would provide adequate traction. So I'm not sure about socks and slippers. Okay, so something about that you may want to evaluate a little further. Okay. And then lastly, would the situation above be any different if the client were 30 years old? If so, how? Explain your answers. Urinary tract infections in young adults typically involve pain of the urinary system, fever, and chills and nausea. Falling is not a risk, so the nurse's interventions for this patient who's 72 would probably not be the same, okay? And we unfortunately don't know how advanced her UTI was and how seriously dehydrated she was. So, you know, maybe the infection was extremely severe where she is, you know, had to have IV antibiotics. So you would definitely implement different measures for someone who's 72 versus who's 30, and unless the patients had some serious history or problems with mobility, probably somebody who's 30 years old, you would not do a risk for falls with that age group. Okay, so this pretty much kind of goes over some of the goals from our National Patient Safety Goals in regards to a patient situation. So I hope this was a good exercise to do, a good activity where you can kind of implement that. Again, we're going back to some of our previous learning when we talked about CUSIN competencies in Nursing 100 and how important it is that we remember some of that previous learning that kind of correlate with a lot of the new information that we're talking about today and which we will talk about in the future. All right. Good job, everyone. I hope you found this helpful and that maybe there's additional information that you could add to some of these questions. All right. But I appreciate you going over this with me. And lastly, since we did leave on the subject of falls, it is a very serious problem that we see happen in acute care settings and any type of healthcare facility. And now that seems to be the question that they ask you when you come in through a ER, urgent care, or even when you're receiving some kind of treatment. I personally had to have some iron treatments in the last few weeks, and every time I went to the infusion center, one of the questions that they asked me on admission was, have you recently had a fall in the last 6 months? And of course I was happy to say no. So this does seem to be a concern that we are really trying to evaluate and look at people who are at risk for falls. Falls happen more to older patients as well as infants, and falls are the leading cause of injury to older patients. More than 1/3 of patients 65 and older will experience a fall. And we see this happen when these people are living alone, and many times when they do fall, there's no help to assist them in getting up. And it can become a very personal emergency response system, where that's why a lot of these individuals have these things around their neck in which they can alert a emergency system to come and to their rescue if they happen to fall, because a lot of these people lay on the ground in their homes and they're not accounted for hours, and this is a very serious situation. So the point is that when we know of neighbors or family members who are living alone and they are at risk for falls, we need to make sure that the home is safe, and we need to make sure that they have some way of communicating to the emergency system that they're in dire need of help because they have just fallen. Okay. The Joint Commission did add those 2 required standards where hospital personnel must assess and manage the patient's risk for falls and implement some kind of intervention or plan of care to reduce those falls. And many times these patients, especially the older patients, have other risk factors that contribute to falling, and it could be that poor vision, they might have some cognitive dysfunction, some of them have some difficulty getting out of bed, they develop orthostatic hypotension because they're on, sometimes it's due to the disease that they're experiencing, or it could be due to the medications that they're taking, and many of them have urinary frequency, or they have that urgency to get to the bathroom, especially if they're on some known diuretics. And diuretics are medications that make them urinate more to kind of decrease vascular volume so that the heart doesn't have to work as hard, and it may also be a way in which it helps decrease their blood pressure. So that's why it's important that we schedule routine rounding, and hospitals are implementing every hour that we assess these patients that are at high risk for falls, that we can go in there and make sure they're safe, and that we could offer them assistance to the bathroom or whatever toileting they may possibly need. Looking at, is this patient need side rails, and would they be a good candidate for some of the electronic safety monitoring devices? And again, being aware of these alarms in case they do go off, that we can immediately attend to the patient and determine if the patient is at risk for falling. So just something to think about, because I know on some of the hospitals, when they did do the risk assessment for falls on a particular patient, they would put a leaf outside their bedroom, their hospital room, and a leaf was a sign of fall, autumn, fall, the season, that patient was at risk for falls. So a person would know before entering the patient's room that they were one of those high-risk patients for falls. So please let me know if you have any questions on any of this material from week 1, day 1, where our concept is healthcare delivery, and our exemplars are healthcare settings, healthcare team members, and national patient safety goals. So this concludes the online lecture for week 1, day 1. And again, if there's any questions, please let me know. In week 2, I will set up some type of chat or WebEx where it's not mandatory, but you're welcome to come on to the WebEx group discussion where I will send out invitations, and any of you who might have questions or concerns about anything with Nursing 121, anything that was uploaded in Canvas, or any of the materials that you're reading, we can go over that to answer any of your concerns or questions that you may have on the material. So please let me know if you do have any questions, and I appreciate your acceptance of this type of delivery, and we're going to do just fine. So have a great day.